This is Panre review. My goal is to be short, succinct, and to the point. So with that, let's get moving. We'll be doing infectious disease today. Patient presents with abnormal discharge from either the penis or the vagina. Patient presents with abnormal discharge from either the penis or the vagina. What should that make you be thinking of? Initially, it should make you think of an STD. The two most common causes of abnormal discharge from the penis or the vagina related to sexually transmitted diseases would be what two infections? That would be gonococcal infections and chlamydial infections. What is the differentiation between the two? In clinic, the way that you would differentiate between either chlamydia or gonorrhea would be through either a swab and a culture, or I believe it's nucleic acid amplification test. We just called that STD testing in the clinic, where they will be giving you a urine sample, and from that you can get an idea if they have tested positive for either gonorrhea or chlamydia. It's also not so important to differentiate between the two because the treatment of gonorrhea and chlamydia is the same. Usually it's recommended to treat for both of them. So whether or not it is gonorrhea or chlamydia, they'll probably end up with the same treatment. You'll give them antibiotics and a treatment that would cover both gonorrhea and chlamydia at the same time. So the signs and symptoms of chlamydial infections include what? Abnormal discharge is the main one and most important, but what other symptoms could also be indicative of a chlamydial infection or be included in the differential? So other than abnormal discharge, what is there? In most cases, actually, it will be asymptomatic. You may catch this on routine screening. A patient may present and say, I had sex with somebody, I'm afraid that they had an STD, and I want testing. They may not have any symptoms at all. The abnormal discharge is more of the grand slam. If they have that, then you're really thinking we've got a clear picture of what this could be. It could also present with dysuria or dyspareunia. What is dyspareunia? Dyspareunia is pain during sex. The way that I remember that is the pair, think of a pair of people, and unia is uniting. So couple uniting, and it's abnormal, thus dyspareunia. That's my mnemonic for that. Hopefully that's helpful for you. Who is at risk for STIs or STDs? I'll use those interchangeably. The people who are at most risk are usually young, single, people who are having lots of sex, meaning that they have multiple sexual partners, and generally homosexuals will also be at risk because of that. All patients with an STD should receive testing for an STD. So it's generally not that specific. If someone presented and they tested positive for a STD, you're usually going to run a panel looking for what additional STDs. If someone had tested positive for chlamydia and gonorrhea, you'll probably also test them for HIV just to make sure that they do not have that, because a lot of these may initially be in an asymptomatic stage. Remember, what is the definitive diagnosis? The definitive way to diagnose a chlamydial infection would be with a sample of the discharge. What is the treatment of chlamydia and what is the treatment of gonorrhea? Remember, you're going to treat them together. The treatment is 250 milligrams ceftriaxone IM, doxycycline 100 milligrams 2 times a day, or azithromycin 1 gram 1 time. So ceftriaxone plus doxycycline. The way I remember doxycycline specifically for chlamydia is clam. Clams are found where? Clams are on the docks. So chlamydia is treated with doxycycline. And the specific dose of doxycycline would be what? The specific dose of doxycycline would be 100 milligrams 2 times a day times 7 days. And that is chlamydia trachomatis. Now, we already mentioned its companion infection. The name of that would be gonorrhea. That is caused by the bacteria Neisseria gonorrhea. What type of bacteria is this? I've actually seen this present on a lot of different tests. So a lot of times they'll say a patient has a bacterial infection. Under microscope, it is a blank. What is the diagnosis, or how do you treat this condition? The description of Neisseria gonorrhea under the microscope would be a gram-negative diplococci. Gram-negative diplococci is what will get you thinking of Neisseria gonorrhea, and the treatment of gonorrhea is what? We just reviewed this. It is ceftriaxone 250 milligrams IM, and you will also be treating chlamydia with doxycycline 100 milligrams BID for 7 days. The other treatment you can use for chlamydia, if you're not going to use doxycycline, would be what? That would be azithromycin. When you are treating an STI, what is something that is important to remember? Whenever you are treating an STI, you want to make sure that you report to the CDC, and the treatment will be that individual and all sexual partners that they have come into contact with. Remember, what is the workup for abnormal discharge? Abnormal vaginal or penile discharge will be a swab and a culture. You can do a CBC if you want. Nucleic amplification test is probably the most important. And in general, if it's a female, what other specific test would be important to run? Considering this is a sexually transmitted disease, it would probably be worthwhile to know if this individual is pregnant. So while you are testing for STIs, you should also get a pregnancy test. Now, in the Panre review, they don't list this other infection that can cause abnormal discharge. It's more common among women. What is another cause of vaginal discharge that is bacterial? Because the non-bacterial one, the probably the most common cause of non-bacterial vaginal discharge would be what? The non-bacterial would be a fungal infection, candidal infection, and the treatment of that would be fluconazole or diflucan. So how would you identify that? So as part of your workup for vaginal discharge, you may also want to add what test? That would be a KOH. But there is one other one that's worth noting, and that is the infection that I am thinking of is trichomoniasis. Trichomoniasis is what type of an infection? Trichomoniasis is actually an STD that is caused by a protozoan parasite, Trichomonas vaginalis. The symptoms would present identical to the other ones. Sometimes, as far as diagnosis goes, you may be able to identify it by doing what? The diagnosis of trichomoniasis can be done through a culture, so you can identify that by getting a urine sample culture, and sometimes under microscope you might be able to see them. The buzzword with trichomoniasis is extremely foul smelling discharge, and so that's the one that they usually use as a buzzword. Not that any discharge is a pleasant smell, but there is a particularly fishy, nasty odor that comes with trichomoniasis. The treatment of trichomoniasis is with metronidazole. We mentioned STD testing. What would you include in a general STD panel? The chlamydial and gonorrhea urine test. Syphilis is a blood test. HIV, you can get also doing a blood sample, and you could also add hepatitis B and C, and those would be used as a blood sample. So the reason, if you remember my mnemonics for hepatitis B and C, because they are sexually transmitted, the A is fecal, and fecal matter comes from your A, and so that's how I remember that one is fecally transmitted, fecal with an A, and an A is where the fecal matter comes from. And then hepatitis B is sexy babe, and B is for babe, and sexy has the C in it. So hepatitis B and C are sexually transmitted diseases and could be included in the general STD panel when you're doing STD testing. So that is what we have for chlamydia and gonorrhea. We have another STI that is sexually transmitted, and it is also one of the more common one. This would be HPV. What does HPV do? HPV produces epithelial tumors of the skin and mucous membranes. Who is at risk for HPV? The same risk, people at risk would be those who would be at risk for any STI. That would be usually young people who are having a lot of sex with multiple sexual partners, specifically homosexual. That doesn't mean that it is specifically a homosexual person. It can be a heterosexual person, but that is a group that tends to be that. Generally, in the patient's history, if they're honest, they will be giving that to you in their social history, that they are having multiple sexual partners. So all boys and girls 11 and 12 are recommended by the ACS to receive what? They are recommended to receive a vaccine. The name of this vaccine is what? The name of vaccine for HPV is Gardasil. Now, you probably don't need to know what specific strands of HPV it tests for, but for fun, the HPV strands are 6, 11, 16, and 18. 70% of cancers will come from HPV 16 and 18. So the Gardasil will help hopefully prevent the transmission of these strands of HPV, which will hopefully then reduce the amount of what type of cancer is generally related to HPV. The type of cancer related to HPV would be cervical cancer. Generally, how would you diagnose HPV? The diagnosis should be straightforward and is made on physical exam. The description of what a HPV genital wart would look like would be a genital wart. The description that is given is small cauliflower-like bumps or tiny stem-like protrusions. One of the things to remember with HPV, because of its relation with cervical cancer, whether someone has HPV or not can change their recommendations on pap smear and pap screening. One of the things that they will do as well is they can do tests to identify HPV in the pap testing. What is the treatment for HPV? The treatment for HPV can be some of the following: podophylax, imiquimod, and interferon alpha. You could also use cryosurgery, electrosurgery, or surgical excision, and generally that would not be done in general practice but would be referred out, and it would have to be a very severe HPV infection, and someone who would be more likely to have a severe HPV infection or outbreaks would be what type of individual? A person that would be having severe problems with HPV outbreaks, just as any viral outbreaks, if they were chronic, recurring, and severe, would be an individual who has immunocompromised status. It was also listed on here 2 other treatments for HPV. I don't know if this was specific to warts or genital warts, but it's a good time just to give yourself a short quiz on how do you treat a typical wart. Some of the most standard treatments for a typical wart would be compound W salicylic acid, and duct tape truly does work. I don't know if they're using that on genital warts yet, but it creates a funny image. Remembering vaginal discharge, if you recall, as part of the differential, we had Neisseria gonorrhea, chlamydia, we also had trichomoniasis, and the other one was vaginal candidiasis. How do you identify vaginal candidiasis? How do you make this diagnosis? Because the diagnosis, just by vision, it may have a particular look about it, but to be more concrete and definitive in your diagnosis, you will not just base your diagnosis off of physical exam. It looks like a candidiasis infection. Instead, you will take this and you will put it under a microscope and do a KOH test. And under fluorescence, it should turn, I believe, purple. It's been a while since I've been in practice, but the color will change, and based off of the color, you can then identify that this is for sure a fungal infection. So the buzzword for candidiasis would be pseudohyphae on microscope with KOH fluorescent fungi. What are the signs, the symptoms of a vaginal candidiasis infection? Vaginal discharge, dyspareunia, vaginal itchiness, abnormal discharge, pain during urination. The other thing worth remembering when it comes to STDs, because we're talking about the primary presentation. The primary presentation would be vaginal discharge and dyspareunia or dysuria, but depending on the location of the STI, it could also influence where you're getting the discharge. So it doesn't necessarily need to be vaginal discharge, but it could be anal discharge. And people can get these infections transmitted not only in the genitals or in the anus, but they can also cause pharyngeal infections as well. So that's why the history is always important when you're looking at particular exposures and the infections and how you're going to treat them. What are some of the risks of contracting vaginal candidiasis? So if you think for a second, the primary risks of getting vaginal candidiasis would be obviously an exposure somehow. But recent antibiotic use would be one of the big buzzwords for that. The other one that, if you're looking at a very common comorbidity, causal relationship, would be diabetes. People who have diabetes and their sugars are not managed well, and they're having A1Cs that are not managed well. They're having a lot of hyperglycemia. Hyperglycemia puts one at risk for fungal growth, and they will be at much higher risk of a fungal infection. Pregnancy, contraceptive, weak immune system are some of the other ones that were listed. Remember, the diagnosis is pelvic exam, sample of discharge. You can, if you're going to be, depending on the process you want to do, a lot of times in clinic it would be this sequence. If you are suspicious of a candidal infection, you may just take the infection, or you may just take a sample of the discharge, put it under KOH, and if it's positive, treat for that and not have to do the other tests. If you want, no one would fault you for just running the other tests, especially since they are easily accessible and ready, and they don't take much time, and especially depending on some of the circumstances, you don't always have to go for a full STI panel if it's just a candidal infection. It could be a patient that just presents, said they started on an antibiotic, or they have diabetes, and they, most of the time in clinic it was, I get these all of the time. And what is the treatment? The treatment, this is a good one to know, just memorized because of its commonality. The treatment of candidiasis, fluconazole oral, 150 milligrams once. Now, I know that there's specific protocols that have been given about how to treat these, depending on how often they are reoccurring. Sometimes the treatment would be take one now and take another one in 3 days and take another one on 5 days, depending on how severe it is. Add another dose if it is severe in 3 days. 1 week for 6 months if it is chronic and recurring. There are some alternatives. Instead of using diflucan, there is monostat cream and turconazole cream, but the pill is very simple and easy. 1 pill once, you're done. So that is the treatment of vaginal candidiasis. But also remember that there is some crossover in thinking about other forms of candidal infection as well. So I have 3 that were not included in this section, but I wanted to go over them because they are relevant at this time. So if a patient presents with vaginal itchiness or just itchiness in the genital region, that itchiness being the primary concern, one of the things that you could identify or be looking for on a physical exam obviously would be that discharge. Now, say they have all of that itchiness and they are negative on a KOH, and you ran a chlamydia and gonorrhea and that was also negative, you could be considering something like pubic lice, and that is known as scabies. Aristotle called it lice in the flesh. Most common symptom is pruritus, particularly nocturnal pruritus. On physical exam, you can see burrows, papules, pustules in the genital and gluteal area or in the web space of the fingers. Mineral oil drop. It may allow you to, like if you drop some mineral oil in the burrow, it may show the eggs. And so again, a lot of this would be based off of some of the patient's history. Sometimes they do have that exposure, but it's usually itchy. So in that region, you'll see kind of, maybe there'll be even some mild excoriation, just some signs they've been scratching a lot. And then on exam, the burrows and papules and pustules in that region may make you think that this could be a scabies infection. What is the treatment of scabies? The treatment is permethrin cream, and you would treat that individual and all household members and contacts. One of the things that I had written down is if you are going to get rid of them, when you are washing your clothes, you want to make sure that the water goes to about 60 degrees Celsius. That's just some extra fun information. Another common STI that is more associated with pain as opposed to discharge would make you be thinking of what particular STI, and that would be herpes. Now, herpes comes as HSV1 and HSV2, but we used to just say that, like, I believe herpes 1 is oral, herpes 2 is genital, but nowadays they don't really differentiate between the two because it's kind of either way, either direction. So a herpes infection the diagnosis would be made by, I guess you could say, two things. Some people will use the diagnosis just based off of the visual. You know that the person is sexually active. You can do on a pelvic examination or even just an examination of the genitals if it's a male. You'll be able to see a small, painful blisters. And it tends to be more blisters, but they're more clustered. So it tends not to just be one ulcerative blister. Sometimes you'll have one ulcerative blister that just shows up in your mouth, and that would be canker sore. I believe the more medical name for that is like stomatitis or aphthous ulcers. So, but those tend to just be a single one. Most of the time when it comes to a herpes, it's like having multiple of those in a cluster. If it was diffuse ulcerations in the mouth, that's probably got to make you think of something else. The only one I know off the top of my head is a particular disease that can cause some diffuse ulceration in the mouth, and that would be Beckett's. There is another form of ulceration that is related to a very rare illness, and it basically is, I think in most cases, tends to be more of a singular ulcer, and it is a bacterial cause. So remember, the typical one would be just a canker sore, but mostly it's one ulcer. Women can have 4 or more. It begins as a small bump. The bump becomes an ulcer. It's a very painful ulcer, has sharply defined borders. It said this is extremely rare. It tends to be more of a traveler's disease. They may have swollen lymph nodes, and this is a very rare one, but it looks similar to herpes, so that's why I want it in your mind. It's just part of the differential, and that is called chancroid. Chancroid is caused by a particular bacteria. The name of that bacteria is what? The name of the bacteria that causes chancroid is Haemophilus ducreyi. Remember, it's very rare. There's less than 50 a year. It's a traveler's disease typically. The treatment of chancroid is azithromycin 1 gram orally and ceftriaxone 250 milligrams IM single dose. These are painful ulcers. Now, I know it's coming up shortly, but what is an example of a painless ulcer? That is a chancre, and that is associated with what illness? The illness that has a painless ulcer, the only one that I can think of off the top of my head, is syphilis. But if we return to herpes, remember we were talking about it as a small, painful cluster of blisters. Sometimes it may just be like one very prominent one. HSV1, a lot of times people get those outbreaks on the lips. It has a straw-colored fluid. The blisters ulcerate. The ulcers heal in generally 7 to 10 days. The individual may have some fever, malaise, some swollen lymph nodes. It's usually not extreme lymphadenopathy, but sometimes I've seen people present with initially just a lot of times with the herpes infections, one of the things that's really useful in the patient history is the patient will say that they can feel it before it comes, that there is some sort of let's call it a paresthesia. That may not be the most accurate term, but I'm using that as an analogy for they sense it coming before it presents. There's like a tingling or a numbness or a slight pain. Something is sensed to be off, and that's typical with HSV. There is another illness that is viral that can do that. People will feel it before it comes on, and that is a chickenpox. But the chickenpox virus, which is what is the name of the chickenpox virus? It is zoster. So I was not making you think of chickenpox. I was just trying to slowly build you up there. And zoster, a lot of times as part of the history, that's something you can get as well. They'll feel it before the rash actually comes on, and that can be very helpful for herpes. Most of the time in clinic, I guess there's a few times you'll get this presenting the very first time ever. If you want, the way to be definitive on the diagnosis is you would do a culture of the blisters and a PCR. The culture would help you rule out Haemophilus ducreyi or some rare form of syphilis, but because it's painful, that should make you think of this, but a culture might be helpful for the first time, and then in subsequent infections, because it's a chronic, lifelong, coming and going, intermittent disease. Most of the time patients are coming in for treatment of it. Treatments include, the primary treatment simply would be what? The treatment, because it's a viral infection, would be antivirals. Specifically, acyclovir, 200 milligrams 5 times a day for 7 to 10 days. Valcyclovir, 1 gram PO BID for 7 to 10 days, or famciclovir, which is 250 milligrams 3 times a day. In order for these to be successful, whenever you're treating any viral infection with antivirals, one of the key things with treatment is you have to catch it early. So when you're educating the patient, you can tell them that when they're feeling those signs of it coming on, if they start the treatment then, it may actually shorten the overall time, because the ulcers generally would heal in 7 to 10 days, so you might be able to make it so A, it's not as severe, and B, that it doesn't last as long. Make sure that you clean it with soap and water. Warm baths can help alleviate the pain, especially if it's in the genital region. One of the risks of a HSV infection is that the ulcer could become infected. And what is the most type of bacteria that would infect one of these ulcerations? The common association would be that these can progress into a staph infection, and staph infections are treated with what antibiotic typically? Most often we just give them Keflex. Moving on, we are going to the illness that I believe it was said, this is how it was taught to me, that if you understood this particular illness, you would understand all of pathophysiology. It is a rare STI, STD. I believe it is what killed one of my favorite composers, and I know I usually don't go on tangents, but he's totally worth it. So if you do not know Franz Schubert, totally great, just as good as Mozart, just as brilliant. His stuff is incredible, and I believe he died from syphilis. The treatment for syphilis is treated with penicillin. Benzathine penicillin, 2.4 million units IM. You could also do 2 grams of azithromycin, but the number one treatment is penicillin. A lot of times doxycycline is also used, 100 milligrams 2 times a day, which is kind of interesting because if you were really concerned about syphilis and they had gonorrhea, remember gonorrhea is treated with ceftriaxone. Chlamydia, you would treat that with doxycycline. Clams are found on the dox, but you could also use azithromycin, and azithromycin could also treat the syphilis if they had that. So what are the signs and symptoms with syphilis? There are tons of buzzwords with this. That is because syphilis has different phases, if you recall. So there is 3 phases. We have primary syphilis, secondary syphilis, and tertiary syphilis. And this is a great opportunity for you to recall off of the top of your head what these 3 specific stages are, since if you are in your schooling, it will show up on a test. Primary syphilis is what symptom? Primary syphilis is chancre. I don't know exactly how to pronounce that, but it was pronounced chancre to me in school, so I will be repeating that. Chancre is what? Chancre is a painless lesion. It is a painless ulceration. So anytime there is an ulceration that is painless, think of syphilis. And your definitive diagnosis will be made with a culture. I believe it's a slow growing one, so there are specific labs that are done as well. And what are the names of these labs that we do? The blood work that will help diagnose syphilis. The blood work that would diagnose syphilis is an RPR and a VDRL. RPR and VDRL. So primary presents with a chancre. What is secondary syphilis? Secondary syphilis, it is thought of, it will present with a diffuse rash that will show up bilaterally on the palms. So it tends to be bilateral, and it is also found on the palms. There's not many illnesses that will cause some sort of a rash on the palms. The other one is a rickettsial infection. I don't know if I said that correctly, but a rickets type infection, and that is Rocky Mountain spotted fever. So if you are ever seeing a rash on the palms of your hands, then you want to beware. I also believe that there is something in the process of endocarditis that you can start to get some lesions that would show on the palms and the hands. So endocarditis, syphilis, as well as Rocky Mountain spotted fever. Then you have tertiary syphilis. And what is tertiary syphilis? What are the signs and symptoms of that? This is why it was called, that's why it was said that if you understood syphilis, you would understand pathophysiology, because tertiary syphilis is the great mimicker. It literally could affect any organ and could cause almost any type of symptom. So could be neurological, could be cardiological, could be renal. And so those are things that we associate it. And the syphilis infection is caused by what bacteria? Syphilis is caused by Treponema pallidum. What type of bacteria is syphilis? It is a spirochete infection. Just as your random epidemiology, 53,000 cases were in 1990. And so that is your syphilis. What does VDRL stand for? VDRL stands for Venereal Disease Research Laboratory. And what does RPR stand for? RPR stands for Rapid Plasma Reagin. There was one other thing that I forgot to go over, and it was during pregnancy, how would you treat a fungal infection? Since I mentioned that pregnancy is one of the risk factors for a candidal infection, vaginal candidiasis. So how would you treat that in pregnancy? During pregnancy, clotrimazole vaginal 2% applied daily for 7 days. Clotrimazole vaginal 2% applied daily for 7 days. Patient presents with flu-like symptoms. What is the diagnosis? Of course, that's why we call it flu-like symptoms. What do we mean when we say flu-like symptoms? Flu-like symptoms generally should be differentiated from cold or upper respiratory infection symptoms, because generally those are less severe. Flu-like symptoms should get your attention because flu-like symptoms are severe. If you've ever had the flu, it is quite unpleasant. Fever, myalgias, chills, tachycardia, cough, sore throat, weakness, fatigue, severe malaise. Patients may present with what we call flu face, and a lot of it is the general observation you have as a provider. This patient does not look well. Whenever they don't look well, it may that alone may be flu-like symptoms. But fever and myalgia, chills, those tend to be more common. It may also present with other upper respiratory symptoms such as cough, runny nose, coryza, earache, sore throat, all the above, all the upper respiratory type things are on the table. But what really makes you think of the flu is patient does not look well, and then the fever, it's generally a higher fever, but it should be higher than 101.5. Last time that I had the flu, took a picture because I was quite impressed, 103.8. And when you're having your temperature increase that much, you're going to go through the process of chills. So the diagnosis of the flu, if you are suspicious of the flu, how do you make the diagnosis? The diagnosis is very easy, so that's why we won't belabor this, because you can do a rapid flu test. You take a little swab and you stick it all the way up in the nose, scratch their brain, patients are uncomfortable, and it will come back positive or negative, and that can help with your diagnosis of the flu. However, there are many, many things that can cause flu-like symptoms. One of the other common ones that can cause flu-like symptoms, that is a virus. Right now, I'm recording this at the time of the coronavirus. So technically, the coronavirus could present with the same exact symptoms. There are, like I said, many, and it's not worth going down the differential. Most of them tend to be viral, so you want to look for any type of very focal, specific locale to see if there is a bacterial infection. But most of the time when you're going through, you may consider doing a CBC. You could do an X-ray. Why would you do an X-ray? That would depend on a particular physical exam, vital signs, and that would be if they have any low oxygen levels, some problem with breathing, respiratory rate. So that would be, I still have dyspareunia in my head, but it is dyspnea, not dyspareunia, dyspnea, or so low oxygen saturation, decreased breathing rate, anything on the physical exam that's looking at the lungs, you may want to do an X-ray, which is why I put this in here, because it is one of the complications of the flu that's worth considering, because the complications of the flu that you want to think about, because the flu causes, at least in 2017 to 2018, 79,000 deaths a year. And this is spread by aerosol. So prevention of the flu, best thing you can do is wash your hands. If you're in clinic, you could consider wearing masks in certain situations, or having the patients wear masks if they are not looking well. So complications, the one that I was referring to with the X-ray is pneumonia. The other complications with the flu is it can cause encephalopathy, myositis, or carditis. What is the treatment of the flu? The treatment of the flu is supportive. So to lower the fever, you can give them Tylenol or ibuprofen. You can give them, again, Tylenol and ibuprofen to treat the myalgias. Make sure that they are hydrating. There is chicken noodle soup that has some magic. Maybe that is somewhat psychological, but I believe that there is some research that can be helpful. Making sure that they're staying hydrated, not having their electrolytes thrown off. They may go on the Bratz diet. If you are able to catch it within 48 hours, you could give them what medication? The most commonly used treatment for the flu is Tamiflu. There is another one called Relenza, which is Zanamivir, and Tamiflu's other name, generic name, is Oseltamivir. So that is how you treat the flu, and that's a very brief review of the flu. Remember, there is a vaccine for it, and it's recommended to get that vaccine. And if you are working in a clinic, That will generally be mandated. It's the people who are at greatest risk of the flu, because again, the flu is a deadly virus, are people who are old, or people who are very young, or people who have some sort of immunocompromised condition. One of the things you may also run if the flu came back negative and the individual had complaints of fever and body aches, flu-like symptoms, a very common viral infection that causes flu-like symptoms is what? Now, I could give it away by just using the term pharyngitis, lymphadenopathy, and headache, but as you now know, just by saying those three out loud makes you know that this is going to make you think of the Epstein-Barr virus. Epstein-Barr virus is a herpes type virus. It is herpes number 4. What are the signs and symptoms? A lot of the times it presents with pharyngitis and lymphadenopathy. I think the worst sore throat I have ever seen on physical exam was from mono, and it had extreme exudates. And he had already been seen. They had drawn a culture. The culture was negative. They had done strep tests, and they said there is not bacteria on this. It was just extreme. And lymphadenopathy. So the lymphadenopathy tends to be part of this, and that would be swollen lymph nodes underneath the chin in the neck region. A lot of times headache is part of this, and the fatigue tends to be quite significant as well. The last time that I had mono, I was in very good shape for running, and it would be pretty easy to go run 12 to 14 miles, and 6-minute miles were kind of casual at that point. And then I got this, and literally 3 weeks later, I'm out running, trying to run 7-minute miles. I think I made it 2 miles, and I was just like, I am beat. And so it can really transform your performance if you are in athletics. There is another athletic thing, concern that you want to think of regarding mono, and that would be what? It is a sign or symptom associated with mono that is particularly relevant with athletes, and this is splenomegaly. Splenomegaly can actually put people at risk for rupture. One person who told me this, they said if that spleen is extremely swollen and enlarged, it really does not take much. A punch to the spleen, just kind of a normal size thing, could cause that to rupture. One of the things that I got from e-medicine was, as part of the treatment protocol, avoid strenuous activity for 3 weeks, which would include especially contact sports, which would be very difficult for an athlete. But remember that can be life-threatening, and that is a condition that sometimes would slide between the cracks. As far as treatment goes, there's not a treatment protocol that I had written down as far as antivirals go. I don't know if there's any specific stuff. If that was something that you could look up on your own, you could see if antivirals have any relevancy in. What up? Mm-hmm. according to eMedicine, it says that acyclovir is the only antiviral drug used to treat infectious mononucleosis in placebo-controlled trials, and that may be even more specific to pediatric. So the treatment would be supportive treatment, avoiding strenuous activity for 3 weeks. What are some of the things you can do to treat the sore throat, the pharyngitis? Ibuprofen, salt water gargles, or chloroseptic spray. How is the diagnosis of Epstein-Barr made? The diagnosis can be made by doing a monospot test. The monospot test is 85% specific and 100% sensitive. What does sensitivity and specificity mean? Sensitivity is true positive rate, whereas specificity is true negative rate. So 85% of the time, if it is negative, then that is 85% of the time it will truly be negative. And it is 100% sensitive, so if it is positive, they positively have an Epstein-Barr infection. Another virus that can cause flu-like symptoms that is an STI that is found generally with people who have high-risk sexual activity, lots of sex, as well as IV drug use, would be HIV. HIV does not have any specific features. It presents with flu-like symptoms. It is specifically a retroviridae lentivirus. Retroviridae virus. It is transmitted through blood, semen, and vaginal fluid. And the diagnosis of HIV is made, the more definitive is ELISA and a Western blot. So you would do an ELISA test, and if it is positive, you would get a Western blot done. HIV is human immunodeficiency HIV is the human immunodeficiency virus, and it is associated with AIDS, acquired immunodeficiency syndrome. AIDS is when it is more active. So it becomes AIDS based off of what particular lab that you are monitoring. With someone who has HIV, you would be monitoring their CD4 T cell count. So at what point does it become AIDS? When the CD4 T cell count is less than 500. They stage HIV based off of the T cell CD4 count. So if it is less than 500, they have the acquired immunodeficiency syndrome, and it is stage 1 when it is about 400 to 500, when it's less than 500. It is stage 2 when the T cell count is 200 to 400, and it is stage 3 when it is less than 200. The treatment, now there are guidelines. Some may test you on the name of these guidelines. The name of the guidelines used for treating HIV are the HAART, HAART guidelines. The treatment is antiretrovirals because this is a retroviridae virus. An example of one is dolutegravir. And the other thing to be aware of with HIV is because HIV causes immunodeficiency, and because of that, it puts patients at risk for opportunistic infections. So what I want you to do is list a few of these opportunistic infections. It's nice to have a few of these off the top of your head. Candidiasis, cytomegalovirus, tuberculosis, cryptococcal meningitis, and I think it used to be PCP, pneumocysto pneumonia, but I believe that has changed to pneumocysto gyrovi, the same thing. They've just changed the name on us. And that would be the HIV infection. One of the things that I wanted to point out with Epstein-Barr virus is there is some, it's a complicated thing that does present in clinic, and it would be, people refer to it as chronic Epstein-Barr virus. Sometimes individuals will present just with chronic fatigue, and one of the things you can do in your workup is you can do blood work for Epstein-Barr. So instead of just the simple mononucleic test that you run in clinic, you would get blood work, send that to a lab. You would basically get this big old chart that you have to look at and interpret it. It's not worth memorizing it. And if a teacher tested you on that, then they're just evil. And you would be able to look at the chart and be able to identify it if they have a past infection, if they have an active infection, and sometimes that's one of the ways that Epstein-Barr virus will present in adults. And again, that's more, think of it like a reactivation of the Epstein-Barr virus. When you're doing your screening, most of the time you will be doing just a simple antigen antibody test in the blood work. And then if that is positive, I mean, that's when you start to think of an ELISA test or a Western blot test. Again, just depending on the particular levels of exposure and how much you want to chase those down. The specificity and sensitivity of HIV testing it states that the HIV 1 to 2 RDT kit showed 100% sensitivity and 100% specificity with whole blood specimen, and 100% sensitivity and 82.86 specificity with serum specimen for the detection of HIV-1. And then they gave positive predictive values as well, and that would be 85 and 82%. However, unless things have changed, it was still, when I went through e-medicine, that they put the ELISA and the Western blot to confirm as still the gold standard for the diagnosis of HIV. But it is important to know that when you're doing your general screening panel for STIs, remember you get the urine sample, you do a culture, and you can also do the blood work that's going to be testing for syphilis, the RPR, the VDRL, and also test for HIV. All right, this is the bane of our existence when it comes to infectious disease. And it is because you have 4 illnesses that have very similar names. And these 4 are rubella, rubella, roseola, and rubeola. rubella, rubella, roseola, and rubeola. So expect to see people try to throw you off on these because that's what we like to do as human beings, to be tricky and pull tricks on people. We will throw all 4 of these at you. Rubella, rubella, roseola, and rubeola. How do we differentiate between these? So some of the tricks that I have, rubella, the Bella is little red. Rubella, for some reason that's been easier for me to remember. Rubella, for some reason, Bella makes me think of little. Maybe that's because you think of Bella in that stupid vampire movie. She's a little girl, Bella, rubella. Okay, so that's little red, and that will become important. Its other name is German measles. She falls in love with vampires, and vampires are close to Germany, right? Because that's where Transylvania is close to. So rubella, little red. Think of stupid Twilight. It's a little girl and some vampires close to Germany. So rubella is little red, aka German measles. Rubella is a paromyxovirus, and that's the one for mumps. Rubella. Rubella is mumps. And it does have a U. It has 2 U's in it, so it's got the RU, because most of these have, like rubella has a RU, rubella has a U, but rubella has the 2 U's. So that U can make you think of mumps. That one's a little bit easier to remember. So rubella, little red, German measles. Then you have rubeola and roseola. And both of those have that E in there, Rosie and Ruby. That's how I remember it. Rosie and Ruby both have a common finding, and that is they both have a high fever, right? Rosie and Ruby are girls' names, and think of them as high. Rosie and Ruby are high. Rosie and Ruby are high. So the E, for some reason, the E can be a high thing, whereas rubella, the E is a higher pitch sound, and rube, the is a lower pitch sound. Little red, Rosie, higher inflection. So if it's Ruby or Rosie, it's high fever. Meaning if it's a low fever, you got to be thinking rubella. Now if it is a high fever, this is where you can now say, okay, it's high fever, it's either roseola or rubeola, and how do you differentiate between the two? So if there is a fever, and then the fever is over, remember it was a high fever, and then the rash appears, then that is more typical of roseola. If there is a rash on the face that moves downward, it comes on day 2 to 5, but it can also be during the fever, that is rubeola. Rubeola is more associated with during, okay? During the fever, but the fever ends and then the rash appears, that will make you think of roseola. That one's not as that one may be a smaller one. People love to throw out these fever ends and the rash appears. Fever ends and the rash appears is probably most typical of roseola. The fever ends, the rash appears. You love the person, you had a great date with Rosie, and then what happens? The next day, you're going to see flowers. So once the fever ends, the rash appears, the flowers appears, maybe it's similar. That may not be the easiest way to remember that. One of the other bigger things for differentiating rubeola versus roseola is roseola usually does not have very many upper respiratory symptoms, okay? Whereas rubeola tends to have much more upper respiratory symptoms. It can have conjunctivitis, coryza, cough, and it may also have Koplik spots. So rubeola has much more upper respiratory infection symptoms, whereas roseola does not. So So why does this get really confusing? Because if I just said the fever ends and the rash appears, you would think, oh, that must be roseola. But guess what? That also happens with rubella. But rubella is trickier because it's little red. It usually does not have a high fever. It's a low-grade fever. Remember, high fever with rubeola, it's not uncommon for it to go higher than 104. And a high fever of 104 is also common in roseola. So very high fever, that's how you're going to make that first separation. Now, if they have a low fever and it begins with this low fever, the fever goes away and then a rash appears, that could be rubella or roseola. You're going to make the differentiation on the fever, how intense the fever is. Now, you differentiate rubeola from roseola because rubeola has what? Rubeola is going to have more upper respiratory infections because rubeola has a U in it, and the U is for upper respiratory, whereas roseola does not have a U in it. So it does not have upper respiratory symptoms, and that only applies to roseola versus rubeola, okay? They both have a high fever, but rubeola has a U in it, so it has upper respiratory symptoms. Rubella also has upper respiratory symptoms. A lot of the times, it can have eye pain, conjunctivitis, sore throat, headache, body aches. But how do you know the difference between the upper respiratory symptoms that you may find in rubeola versus the upper respiratory symptoms you could find in rubella? And that would be rubella does not have the high fever. Isn't this crazy? It just drives you crazy thinking through this, but the initial way that you separate it is, remember, fever. How high is the fever? If it's very high, it's either going to be rosy or ruby, okay? And if it's ruby, it has a U, it's got to have upper respiratory symptoms. That's going to be the way that you differentiate it. And then if it's rosy usually does not have very many upper respiratory infections. And remember when you went on a date with Rosie, what happened after the date? You got her flowers. So after the date, in this case the date is emblematic of a fever, the fever ends, the rash appears. Okay. Now that you have all of that, roseola is herpes 6 virus. Roseola is herpes 6 virus. Signs and symptoms. High fever. Sometimes it may cause febrile seizures. It does not have very significant upper respiratory symptoms. It may have, this is one of those buzzwords, I've never seen this on a test, Nagayama spots, which are erythematous papules. The fever ends and the rash appears. Small, pale, pink papules, or a macular papular rash. It is blanchable, and it is usually not very itchy. So it's just a maculopapular, not very itchy rash. Why do we go through all of this pain? Because the diagnosis is a clinical diagnosis. The main complications would be a seizure, and the treatment would be supportive. So fever ends, then rash appears. It's a high fever. Think roseola. Rubella is rubeola. Rubella is little red. Rubeola is it's a super infectious disease, and its other name is measles. Ruby me. For some reason that has always stuck in my head. Ruby me is measles, and measles is super infectious. And measles has a high fever, and it also has upper respiratory symptoms. High fever, greater than 104 degrees or 40 degrees Celsius. It lasts about 4 to 7 days. 1 in 1,000 die is what this says. I got that from eMedicine, and that would be more typical in children. So it is definitely something that we want to prevent outbreaks. And how do we prevent outbreaks of these? We give people vaccines, the MMR vaccine. There is also I believe there is an immunoglobulin that exists if you did have measles that you could take to help treat this. So conjunctivitis, coryza, and cough. They may have Koplik spots. What are Koplik spots? Koplik spots are bluish-gray specks or grains of sand appearance in the mouth. The rash begins on the face and then moves downward. And the rash usually appears on day 2 to 5 during the fever. Okay? If the fever ended and then the rash showed up, you're thinking this could be more roseola. Treatment is supportive. The complications would be deafness, pneumonia. 1 in 20 get pneumonia. 1 in 1,000 get encephalitis. 1 in 1,000 children die. So measles is nothing you want to mess with. That's why we should vaccinate kids. Now, going back to rubella, Bella, little red, little girl who's in love with a German Transylvanian vampire, and that is rubella. Signs and symptoms, days 1 through 5, eye pain, conjunctivitis, sore throat, headache, body aches, low-grade fever, anorexia, nausea. After the fever and the coryza fades, day 3 through 6, they get a rash. The rash begins on the trunk and extremities. It begins on the face and then comes down to the trunk and extremities. Why is that important? Because that was the same with measles. So little measles and measles are different in that measles has a high fever, little measles, German measles, little red does not. And so but they do have that similarity where the rash begins upwards and moves downwards. Low fever to no fever, mild cold, red-pink pinpoint rash. The rash fades in 3 days. The treatment is supportive. It may be NSAIDs for symptoms, and you can prevent all of this madness by vaccinating your kids. And that is the big 3, rubella, rubeola, and roseola. So take 5 seconds just to say in your mind, what are the 3? Roseola. What is roseola? Pause for you to answer. Rubella. What is rubella? What are the signs and symptoms? What are some of the mnemonics? Pause and answer. And what is rubeola? Rubeola's other name is what? What are the signs and symptoms? How do you differentiate this from roseola? Now, if you didn't forget or die, then we can talk about the rubella virus. And the rubella virus, its other name is mumps. Generally, we just call it mumps. We don't think of it as the rubella virus, but I wanted to point out that it's called rubella just because there are evil people on this world who want you to fail, and they would throw that name on a test question. Rubella has 2 U's. 2 U's is mumps. And why is the 2 U's important? Because it affects 2 things that are found in men, and they are the testicles. So it can infect the testicles and cause orchitis, but the most common sign of monks, the giveaway, the grand buzzword associated with mumps is parotid enlargement. They have this pretty substantial facial swelling because the parotid gland has enlarged, but it may also, as a complication, lead to enlargement of the testicles because the testicles get swollen, and that is orchitis. Other complications are thyroid or pancreatic problems, salivary gland enlargement, edema, lymphocyte infiltration, upper respiratory symptoms with swelling in the jaw, parotid enlargement. There was 650 cases of mumps in 1998. That is not very many, whereas in 1968 there was 153,000. Why such a change, you might ask? Oh, it is this grand scientific discovery of vaccinations. The treatment of mumps. Because it is a virus, there tends to be a very common theme among viruses, and that is that you cannot treat them. They must run their course. There are a few that it's worth doing antivirals, and I'm sure that in very significant cases there are protocols for using antivirals in nearly any viral infection if there was some sort of immunodeficiency or during hospital medicine to warrant them just as a trial, just to try and give some protection. But in general, it is self-limited. You would do supportive treatments. There is an MMR vaccine, if you didn't know, and that can help prevent mumps. And the goal, if you were to encounter most of these, is to isolate the individual so that you can prevent an outbreak. Because one of these is quite bad. It seemed like the worst of them all, based off of its infectious rate and its mortality rate, would be measles. And so measles is super infectious, and has a higher mortality rate. It is not one that you want to mess around with, and that is rubeola, measles, and that one has a high fever. Usually the rash will occur during the fever, and the rash appears upwards and moves downward, and it is rubeola. It has a U in that, measles, and that will have upper respiratory symptoms, much like the little red will, the little measles, the little German measles. Fifth's disease. What is Fifth's disease? Fifth's disease has a fancy name, erythema infectiosum. Fifth's disease, I believe, is called Fifth's because it is the herpes number 5. Delete that. It is not called Fifth's disease because of number 5. So erythema infectiosum's other name is Fifth's disease. It is what type of virus is erythema infectiosum? It is a parvovirus B19. And this will infect mostly kids aged 3 through 12. Now, what is the telltale sign of Fifth's disease or erythema infectiosum? The grand sign of this would be slapped cheek, meaning they have very bright red cheeks. So it's like a rash. It's this erythema on the cheeks. What other symptoms may present with erythema infectiosum? The other symptoms could be fever, sore throat, abdominal discomfort, and there may be some erythema and vesicles. Most typically, there is a fever, and then the rash appears. And what is the rash? The rash is the slapped cheek. So the fever tends to resolve, and then the slapped cheeks occur. This is supportive. It's usually not a big deal, but parents usually get quite scared because the slapped cheek appearance makes them think that there must be some very terrible, horrible disease that their child has got. So a quick timeout. There are multiple herpes viruses. Herpes HSV1 and HSV2 are the typical herpes viruses that we think of with genital herpes as well as oral herpes. But there are other ones. What is herpes virus number 3? Herpes virus number 3 is varicella. What is varicella? Varicella is the varicella zoster virus, and that is herpes 3. Herpes virus number 4 is cytomegalovirus. Herpes virus number 4 is mononucleosis, Epstein-Barr. Herpes virus number 5 is cytomegalovirus. Herpes virus number 6 is roseola virus. And what is roseola virus? Rosy does not have a U in there, so there's not many upper respiratory symptoms. It has rosy was really nice, and you're going to get rosy flowers, and you're going to get her flowers after the amazing date. So after the fever, the rash appears, and it is a high fever. There is also a herpes virus number 8, And herpes virus number 8 is Kaposi sarcoma. And if you did not catch that herpes virus 6, they have herpes virus 6A, 6B, and 7, and those are all forms of the roseola virus. Herpes virus number 3 was named what again? That was varicella zoster. Varicella zoster virus there are 2 illnesses or disease syndromes that are associated with the varicella zoster, and that would be what 2 diseases? That would be 1, chickenpox, and 2, shingles. The herpes zoster virus is acquired through droplets. 90% of the cases under 10 years old will present with this initial infection that we call chickenpox. And how do you describe chickenpox? A lot of times the testing phrase of choice is small erythematous macules or crops of lesions. Crops of lesions is one of the buzzwords associated with herpes zoster. The one that I like the best is central umbilication and crust formation, vesicle surrounding an erythematous halo, and probably the best and most poetic of all, the Shakespearean description of chickenpox is dewdrop on a rose petal. How do you make a diagnosis of chickenpox or zoster? The diagnosis is on a Zank smear. Zank smear, T-Z-A-N-K smear. Culture serology can also be done to prove if there is immunity. What is the treatment of chickenpox? We'll start with chickenpox. It is observation. You want to make sure the lesions don't get infected. And what is the most common bacteria that will infect lesions? That would be a staph infection treated with Keflex. If they are immunocompromised, you can consider using antivirals. Now, the second condition associated with this is the one that it has the actual name. We'll call it shingles. Its other name, obviously, is zoster. What is zoster? Zoster is a rash, and the rash is a unilateral, painful rash. It can have pain before the rash. It can have tingling before the rash, and that helps. But it's usually one specific spot. It's very painful, and it's on half of it, and it's affecting a dermatomal region. And so those are the main signs, because the diagnosis is a clinical diagnosis when you're looking at zoster. It tends to be quite straightforward. It's just, as mentioned, it's going to be this rash that's affecting just one specific dermatome, which means that there's some pretty defined borders on it, and it's very painful. It tends to be in people over the age of 50. There is a Zostavax vaccine that can be given at age 50, but the CDC says that you can give it at age 60. Again, the diagnosis is very painful, blisters on one dermatome. They may have lymphadenopathy, and remember that the pain or that tingling before the rash develops is also somewhat pathognomonic for this. The treatment is, if you can catch it early enough, you may be able to try using antivirals, but most of the treatment is supportive, and the treatment would be with pain. Morphine, Ultram, ibuprofen, Tylenol, whatever is needed to do it. One thing that is quite helpful when you're treating is you could actually use the topical anesthetics. That can be helpful. Wet to dry dressings with sterile saline may also be helpful. You want to make sure that you're going to prevent a secondary infection from staph, and so that you don't have to pull out your Keflex. moving forward, we have tuberculosis. What is the name of the bacteria that causes tuberculosis? The name of the bacteria that causes tuberculosis is mycobacteria. The risks of contracting tuberculosis would be what? The risks for tuberculosis are exposure, a known exposure to tuberculosis, someone who has traveled to a place where it is not well controlled, someone who is homeless or immunocompromised. Remember that association with HIV. What are the signs and symptoms of tuberculosis? There are two that were specifically, we'd say that when I was being taught about tuberculosis, two that have really stood out, and that would be the cachexia, can also be a sign of tuberculosis, and significant night sweats. Coughing up blood would also be I would say those are the big three. In general, the signs and symptoms include cough, weight loss, anorexia, fever, night sweats, fatigue, coughing blood, chronic cough, chest pain, fever of unknown origin that comes and goes. So some of these have some similar cancer-like symptoms. The reason why Mycobacterium tuberculosis is tricky is because the rate at which it grows is so slow that it may present with these very obscure, mild symptoms that seem like they're coming and going until it really grips you and becomes more significant. The risks of Mycobacterium tuberculosis are it can lead to pneumonia, meningitis, skeletal TB. It can also penetrate into the gastrointestinal system or the genitourinary system. The diagnosis, a PPD skin test, interferon gamma release assay for TB, or a sputum culture. What is the problem on a sputum culture? It is that this just grows very, very slowly. So if you were suspicious of it, you can do a PPD skin test, and then you will see that reaction occur. And I don't know much about the interferon gamma release assay for TB. What I know about the specific test, the interferon gamma release assay, which it's an assay so it has multiple, is that you can usually get your results within 24 to 48 hours. The number they put, I think, on the CDC was 30 hours. And the sensitivity may be estimated around 84%, and the specificity, and that would be around 97%. Remembering what is sensitivity and what is specificity. Sensitivity is the true positive rate. Specificity is the true negative rate. The mnemonic I've used to remember the difference between the two is sensitive people. It's a truly positive attribute to have if you are extremely sensitive. So sensitivity is positive, and people who are specific and very overly specific, it tends to be a negative trait. Think of like an obsessive compulsive personality disorder trait. You're too anal because you're too specific and meticulous. That's a negative thing, whereas sensitive is generally a very positive thing. So true positive sensitivity, true negative specificity. Moving onward, we have a patient presenting with a rash, and the rash ends up exposing, and you can see the rash on the palms of the feet. The rash appears on the palms of the hands and the soles of the feet. There are not many things that will cause that. Maybe this is endocarditis. Do they have any of the other symptoms of endocarditis, such as what? Maybe a heart murmur, some sort of exposure, IV drug use, any chest pain, any of the other symptoms, the Janeway lesions, the Osler's nodes that you could find that would be typical of endocarditis? Or has this person been camping? Or have they been having sex with random people? Because rash on the palms of the soles can be found with endocarditis, it can be found with syphilis, and it can also be a tick bite. A tick bite could cause Rocky Mountain spotted fever. It's very difficult to diagnose. You usually only have a history of exposure to go on and a rash on the palms and the soles. Otherwise, the signs and symptoms are going to be flu-like symptoms, fever, headache, malaise, maybe some sore throat, some upper respiratory symptoms, fatigue, headache. Signs and symptoms are usually 1 to 4 days of flu-like symptoms, and then by day 5 and plus, it can progress into organ failure, which could include things such as cerebral edema, which would be causing an altered mental status, pulmonary edema, necrosis. So this is a very significant illness. It says it's difficult to diagnose and 80% of people will die. Primary risk would be the exposure to the tick bite. Hospitalize if it is severe. Doxycycline 100 milligrams PO IV 2 times a day for 5 to 14 days. Chloramphenicol is used if you are pregnant. The buzzwords are rash on palms and soles, rash usually a day or two after the fever, and the cause is what? It is a bacteria, Rickettsia rickettsii. It is a gram-negative bacteria. Perhaps if an individual was known to have been camping at all and then within a day or two got sick, I mean, obviously if the patient said that they got bit by a tick and then now they're sick, you should probably just give this patient some prophylactic treatment, doxycycline, if they have flu-like symptoms. I don't know how far to go. I've never run into this in clinic. I don't know if you hospitalize them. I mean, if they have a known tick bite exposure and they have a flu-like symptom and they are flu negative, you can run the other tests. You may want to consider very closely watching any individual who has a known tick bite, and maybe even consider some sort of prophylactic treatment if they have been camping and just so happen to unfortunately get a flu-like syndrome within a couple of days after their camping trip. There is another type of rickettsial infection, whereas Rocky Mountain spotted fever is found in what type of area? That would be the Rocky Mountains. There is one that is more found in the upper eastern area, and that would be what illness? We are talking about Lyme disease. Lyme disease is the most common vector-borne illness. It is caused by what bacteria? The bacteria that causes it is Borrelia burgdorferi. The risk factors are exposure to the tick bite. It generally presents with flu-like symptoms, fever, chills, malaise, myalgias, arthralgias, tends to be something a little more specific that may make you think of Lyme disease, headache, erythema migrans, or bullseye rash is the main thing that you want to be thinking. So someone who has flu-like symptoms and bullseye rash, you should very much be thinking Lyme disease. That is your buzzword. That is your pathognomonic. that you can at least think of. You have to be able to associate bullseye rash with Lyme disease, bullseye rash with fever, tick exposure, Lyme disease. Lyme disease does weird things. What weird things would Lyme disease do? It can infect nerves. Cranial nerve number 7, it can cause meningitis, it can induce Bell's palsy. The diagnosis of Lyme disease is made how? Well, remember, from physical exam, you're thinking of what? Bullseye rash, and you are thinking of that with the flu-like symptoms. But the ultimate diagnosis is going to be the immunoassay, immunofluorescence, total Lyme titer, IgG, IgM, and you would use a Western blot to confirm. So although the term erythema migrans means rash that comes and goes like it's migrating, the reality of erythema migrans is these lesions will appear at the site of the tick bite, usually 1 to 33 days within that time frame, and without therapy, the erythema migrans typically fades within 3 to 4 weeks. So remember, the description of the erythema migrans is a bull's eye rash. The Western blot is used to confirm, but there are multiple tests that are used in the process of diagnosing Lyme disease, and that would be immunoassays, immunofluorescence, total Lyme titer, IgG, IgM, and the treatment is what? Doxycycline, 100 milligrams 2 times a day. It may require IV antibiotics if the symptoms are severe or there's complications. What is the name of the illness that is an autoimmune inflammatory process? Remember, autoimmune and inflammatory. It's an autoimmune inflammatory process that develops as a sequela of streptococcal infections. This is acute rheumatic fever. So it is associated with strep infections. However, it is not a bacterial infection. It is the autoimmune inflammatory process that develops as a response after the strep infection, and that is acute rheumatic fever. Acute rheumatic fever has many different signs and symptoms associated with it. The signs and symptoms that we remember would be carditis, polyarthritis, are carditis and polyarthritis. The diagnosis is using a particular type of criteria. This criteria is called Jones criteria. The Jones criteria is what we call carditis and polyarthritis. Those are your major criteria, or chorea. And then there's major criteria and there's minor criteria. The major criteria, according to Jones criteria for the diagnosis of acute rheumatic fever, are carditis, polyarthritis, chorea, nodules, or erythema marginatum. The minor criteria are fever, polyarthralgia, and an ESR, a high ESR. The signs and symptoms of acute rheumatic fever are variable and nonspecific. They include things such as we mentioned before, chorea, non-supportive inflammatory lesions, subcutaneous nodules, arthritis. Typically, it is polyarticular and it is usually bilateral. Lesions in the joint, lesions in the heart, subcutaneous tissue. These lesions, again, are an autoimmune response, and so they can be affecting many different places. If they have carditis, what types of symptoms are associated with carditis? Carditis is infection of the heart. If you have infection of the heart, you could expect to have chest pain, dyspnea, shortness of breath, cough, edema, or even cardiac failure. And that cardiac failure would be, again, the edema that's building up, but that chest pain would be one of the main things. The arthritis usually lasts 4 to 6 weeks, and it usually will not have long-term effects associated with it because a lot of the arthritises, such as rheumatoid arthritis, has more of a long-term effect and causes damage. The other thing that can be helpful for the diagnosis is a throat culture, an ASO antibody titer, and an ESR. What is the treatment of acute rheumatic fever? You want to make sure that the streptococcal infection has been cleared, because the fact that it has not been cleared, it may be continuing this inflammatory process that's somewhat exaggerated. And so penicillin to clear out the streptococcal infection. And then aspirin is used. Salicylates are preferred as the treatment, not steroids, even though we're thinking autoimmune and inflammatory process. Despite that, aspirin is the preferred treatment. We mentioned one of these signs and symptoms, and that was erythema marginatum. What is erythema marginatum? Because we know what erythema migrans is, that is bullseye rash, Lyme disease. Erythema marginatum is a type of erythema involving pink rings on the torso and inner surfaces of the limbs, which come and go for as long as several months. It is primarily found on extensor surfaces. So a rash that is coming and going, you would have to look it up online to get a description, because that's all that I could find. Patient presents with muscle tightness, spasms. They're unable to move their jaw very well, so they may have somewhat of a mumbled speech, and their jaw is very tight, so they're not able to, like I said, talk very well or move or chew very well. What are you thinking of? There are a few things that may cause some similar symptoms. The individual does not, you look in their history, they have not been vaccinated ever, so you are thinking of a particular type of bacterial infection that can cause this locked jaw or trismus. It is tetanus. Tetanus is caused by what bacteria? Clostridium tetani, found in dirt, lockjaw. A lot of the times there are metallic Things like nails. People step on a nail. You're going to make sure that these individuals are getting a tetanus shot, that they have been up to date on their tetanus shot. We do a DTaP for kids, a TDAP for teens, and a TD for adults. Touchdown, adults love touchdown football. TDAP, teens be dapping everywhere, dabbing, and kids are always tapping you. So that's how I think of that. The signs and symptoms of tetanus: muscle tightness, spasms and pain, can cause lockjaw, fever, usually diffuse spasm, pain, and fever. Risk factors: generally individuals who have not been immunized, they have a recent exposure, something such as a puncture wound, dirty, deep wounds, dirty wounds that are deep, tends to take about 3 to 21 days to incubate. The average is about 10. Death can occur. Why would death occur? What is the association with spasms and death? If there is a substantial spasm of one's diaphragm, then they can die by suffocation. What is the treatment? If someone has and presented with something like lockjaw and you are suspicious of this, immediate hospitalization, IV antibiotics, and an antitoxin. What are the antibiotics used? The antibiotic that is used to treat Clostridium tetani is metronidazole. The antitoxin is an immunoglobulin. Individuals for the spasm may take diazepam, a benzodiazepine, or even magnesium can help for spasms. There is also, you also want to revaccinate the individual. It says 1 to 2 out of 10 tend to be fatal. So this is a very significant one, which is why we should just prevent it by getting vaccines. Patient presents crazy. They've had an acute behavioral change. You also notice that this individual is severely dehydrated and they are not so interested in drinking water. Yes, this is one that is quite an odd presentation because most of the stuff would be very non-specific signs. The specific sign you get is personality change. But the way that you would catch this obscure personality change, behavioral change, would be this individual also has an exposure to an animal bite. This is what you think of with rabies. Now, of course, the foaming at the mouth would have been the dead giveaway, but the foaming of the mouth is secondary to the hydrophobia, and they are usually actually having excessive salivation but are dehydrated as well, so it's a foaming at the mouth. The rabies tends to, when it's more significant, will cause some sort of behavioral change, so anxiety, agitation, insomnia, depression. There are nonspecific signs. We call those the flu-like symptoms: malaise, fever, chills, nausea, vomiting, diarrhea. This can progress into a seizure or a coma because obviously if it's causing symptoms such as behavioral change, then it has a proclivity to affect one's brain. And if it is affecting their brain, then it is reasonable to suppose that it would eventually progress to seizures, coma, or delirium. The sign and symptom is an exposure to an animal bite. This is not an easy diagnosis to make. The animal bites that are most common, about dogs less than 5%, bats, wolves, foxes, coyotes, raccoons, and skunks. The most recent one that happened in our community was an individual had caught a bat. They kept it. The bat had bit him, and bat bites are not very, bat bites are very inconspicuous, and so by the time that they found out that it was rabies, it was too late. It is difficult to treat. You can give one rabies immunoglobulin, that is 20 IU per kilogram. There is a rabies vaccine, 1 milliliter on days 0, 3, 7, and 14. The diagnosis, again, is very difficult to make a diagnosis based off of presentation, history, and physical exam because of its nonspecificness. The definitive diagnosis would be made using a PCR assay, and you can get that from the saliva, CSF, brain tissue, or eye tissue. When you had the option between brain tissue, eye tissue, and saliva, go with the saliva. Patient presents with itchy butt. What is itchy butt? The medical term for itchy butt is pruritus ani. They're scratching their butt. Now, scratching your butt could also be a sign of hemorrhoids. Hemorrhoids a lot of times will cause some itchy butt, or they're just bad hygiene. But if the complaint is a significant prolonged itchy butt that is out of the norm, on the physical examination, you may do something called a tape test. The tape test you can view on microscope, and you may be able to see small little worms. So pruritus ani, itchy bum, I'm making you think of a pinworm infection. Pinworms are Enterobius vermicularis. It is a nematode. Nematode is the fancy word for worm, and so is helminthic infestation. The way I remember pinworm as vermicularis, pinworm, itchy bum, vermicularis, vermin. These worms are small little vermins. The diagnosis is a clinical one. Remember, you can view the worms. It's more easy to see them with a tape test. You might be able to see the small little worms, but it's a lot easier if you put them under the microscope. How do you treat itchy butt? How do you treat the pinworm vermicularis? The treatment of pinworm is metronidazole. The treatment of pinworm is mebendazole. The reason I say it mebendazole is because bend. When you bend over, you can see an azole. And what is in the azole? It is an itchy bum full of pinworms. And that is 100 milligrams one time. You may want to repeat this in 1 week. You can also use albendazole, but just think if you're bending and seeing an azole, that will make you think of bums and what's associated with bums, pruritus ani and vermicularis and helminthic infections. Azoles treat worms, okay? And worms like butts, apparently. You may want to, when you're treating, you may want to not just treat the individual, but may want to treat the entire household. Make sure that you wash the sheets, clothes, towels, and have the patient follow up just to make sure that there has not been a reinfection. Another type of presentation. And lastly, patient presents with a very itchy head. They are scratching their head. It tends to be a little kid. And as soon as you think, man, why do they have such an itchy head? One of the things you may be thinking of is a common infection, and that is lice. Lice is not a bacterial infection. It is caused by vermin as well, but a different type. Pediculosis is the other name for lice. And the way that you diagnose this is based off of history. You can use a fine-combed You can use a fine-tooth comb and microscopic evaluation if you need, and then you will see the lice. Lice is the name of the little bug. It is a louse insect, so they have an insect biting them, and you want to treat all persons who have contact with the infested patient. You want to make sure that the treatment is oocidal, so that you're destroying the eggs. The treatment is permethrin, 5%, and permethrin shampoos. And you want to clean and launder everything, treat the entire household. And again, the diagnosis should be straightforward and diagnosed just based off of examination. You can get lice in the head, but if you have some sort of lice, we'll say, similar lice thing that's infecting the genital region, and that would make you think of scabies. And how do you treat scabies? It's the same thing, permethrin cream. Permethrin, 5%. So if you are suspicious of little bugs running around biting you, whether it's on the top of your head or whether it is in your crotch area, then think of permethrin to save the day. And that's what we have for infectious disease.